That's a bit about me. I've been to Mauritius. This is my fourth trip with Neuram. So just generating the awareness, spreading the message, speaking with the physicians, clinicians, seeing the patients. So trying to understand the problems that we have in Mauritius, and this workshop is a bit towards how to address those problems with current resources that are available. So that's a bit about me. She will let you introduce herself. So you choose the mics. I'll come over here. Is that right? Oh yes, that was I'm Sue. I work in the London Spinal Cord Injury Centre as the head physio there. I've been working spinal cord injuries for more than 27 years. I started as a child. And Amber and I worked together there years ago, and then he moved on. I stayed, and I'm still there, my sins. I've been involved with Neuram in the last 4 years. So, and we've been here before together as a team. We're going to talk to you about the significance of the different levels of the spinal cord and the implications on function and activity. We should say that, again, we're talking about levels from a complete perspective, because it's impossible to talk about incomplete injuries, because it could be any presentation you can think of. So incompletes is something that we will explore, particularly with the functional side of things with our workshops with the therapists. But certainly from a functional point of view, we'll just talk through each level and explain what we'd expect to see and the expected functional abilities that we would expect somebody to get if they were complete. If you can start from there, everything else is a bonus after that, which is where we begin with. Okay. That's what I just said. There we go. Okay, so looking at the highest spinal level, really these patients didn't survive. When I first worked in spinal cord injury, somebody at this level really didn't survive. I probably did see one or two C2 injuries that had been resuscitated and survived with us, and have gone on to be long-term ventilated patients. They now do survive, and we have a large cohort of long-term ventilated patients living in our communities, and that's due to the fact that we have really good ATLS, that's the advanced life support systems in place when somebody's first injured. So there's great public awareness of what not to do and what to do with people. There's a lot more awareness of how to resuscitate across the general public, so that people are resuscitated, and that our ambulance and first responder service know how to actually preserve the spinal cord at the time of injury very quickly. So they have excellent skills in immediately oxygenating the cord so it doesn't die, which is the main cause of loss of these patients at the first moment they get to them, and then good management thereon. So we do see more patients like this now. These patients obviously have a greater incidence of complications and a shorter life expectation. No, we're all right. Yes. I mean, if you think about the level of injury here, you're looking at somebody that's really quite often associated with head injury as well, because it's such a high injury. So you're likely to have an impact of a head injury, which may or may not be massively affecting their function, but it's quite likely that they'll experience issues of memory loss, even if nothing else. So from a psychologist's point of view, the psychologist would probably look at doing quite a lot of cognitive testing to look at the implications of a head injury at this level. But we're looking at somebody who is going to have really just nod and rotation. And so you want to be able to enable them to focus and control their world using things that they can control from head control. They're going to be ventilator dependent. The ventilators now are really, really nice. really small, they can be very easy to attach with the patient in the wheelchair, and they can be quite clever to help use settings on them to enable the patient to time for speaking. And our anaesthetists that specialise in this area are very good at fiddling around, so they enable the patient to actually have a speaking valve and enable their timing for their breath to speak effectively. So you're really looking at somebody who has no activity to do anything else except for control their world.
So, as you said, the activity is very limited, so the function obviously is very limited. So what happens, how do we approach? We still can make the person manage his own care. So education, which we will be emphasizing in every slide, education in management of their condition is most important. So these people of this level would be able to at least tell the carers what to do. So our aim would be to enable them to direct their care. So they are the masters of their own care. So carers can change. These are the people who would be telling carers exactly what to do, and that's our job to train them. They can swallow. They would be able to swallow. They would need a 24-hour care. That means the carer would be needed 24 hours, 7 days a week with the person. We're quite lucky to have some advanced technologies which are voice operated for people to manage their environment. So they're called environment controls. They would be able to use the environment control system to switch on a light, switch off a light, operate their televisions, dictate anything on their laptops, operate their laptops. And then I had a patient who was C1, C3 injury, and he was a journalist. So he successfully went back to the profession with voice-activated software where he could dictate. So that's our C1, C3. So basically, some of the pictures that you can see. They have very specialist power chairs that can be driven with just chin control, lip control, just small movement in the lip, because the controls are so sensitive to pick up any small movement. Our approach then is thinking of the complications. They are not able to move their limbs. They're not able. So thinking of the complications, they are very prone to the arms or legs being in one position. They can get tight, like on contractures. So our approach is to prevent those complications. We would be talking about this in detail in subsequent workshops, but just a synopsis here. And when our patients go in a very specialist wheelchair, we always advise to have a backup chair, which is a manual chair, because these chairs are highly specialist. So anything small that can go wrong means they can't use the chair. So we always say you need to have a small backup chair so you can at least get up on if their specialist chair is not working. The equipments. These are very basic things. So you said ventilators are now very portable. They can be fitted in the back of the chair and patients can go out. Specialist wheelchair, they would need special shower chair or commode chair that has got wheels. And tilting space is a function that we again will be talking a bit more in detail in subsequent workshops. What it means is that it just changes the whole orientation of the person. He's still able to sit because there's no trunk balance, there are no muscles. So there would be flopping. But if we change the whole orientation of the chair, I'm not sure whether we have a picture. They can still sit straight. They can still have the eye control, eye level. They can still be in midline. Drinking system. I thought I would put pictures of this. This is a very, very clever a bottle that can be attached to a person's wheelchair, so they're not dependent on at least having a drink because they come with their arms. It can be very cleverly put around their chin so they can have an easy access. On the bed, in the chair, environment controls as we talked about. So that was C1, C3. Moving on to C4 level.
So at C4 you're starting to look at the diaphragm. So innovation to the diaphragm, 3, 4, 5. So there's potential that you're actually starting to have enough diaphragmatic activity to to be able to manage off the ventilator, part-time or even full-time. So for patients at this level, you're starting to have a little bit more control around shoulder and around the back of the scapula. So a little bit more activity, a little bit more control, full neck and shoulder stability here. Gives them a little bit more to work with. So we're hoping they'll be breathing. There is potential for a patient around these levels of injuries to actually have an electrical stimulation breathing system, and they aren't done routinely, but there are certainly numbers of patients that do have an implanted electrical stimulation system that actually stimulates the diaphragm. We do have a picture in one of the workshops, in the respiratory workshop, and it will enable the diaphragm to contract, and then they can come off their ventilator. And usually they'll stay off during the day and go back on their ventilator at night, because that makes them feel safer usually. But so we're hoping that this person might be starting to breathe. It may be that they'll have a bit of a hemidiaphragm. They'll have one diaphragm that's really active and the other that's not, and it's just not sufficient enough to sustain a long time off the ventilator. So this has to be carefully assessed. And we do that with our anaesthetic team, so we can see whether we can wean. We have a very dynamic weaning approach, and our weaning guidelines are available, and again we can put links to those for you if you need them off of the Neuram site.
So they have some movements in the shoulder, they have head control, and we will use those movements in function. So going back to they are the master of their care, we would educate and enable and empower them with how to manage what complications can arise and how to prevent those complications. They would be, again, with the carers, we expect that they tell the carers exactly what to do in terms of their transfers, in terms of their skin care, respiratory care, as we have talked about. So they are likely to wean off from the ventilator by a strict procedure, we talked about that. So the equipment that they may need is going to the C1, C3 level. So they would still need a hydrating system for their own independence of having a drink when they wish to. They will have a specialist wheelchair. Which would, again, it could be a head control wheelchair, because now we have the head movement, so head switches are quite commonly used, chin control wheelchairs are quite commonly used. Electric bed, which is an essential part in C1, C3 as well, the filing bed, which could help them to sit up when they wish to, in an upright position. Specialist standing frames. So standing is another very, very essential part of the whole management, right from the beginning throughout the lifespan, for its own physiological reason, which we will probably address later. So standing frame in this condition would be a very, very supportive standing frame, and maybe Sue, you can put a bit more on what types of frames are around.
Yeah, we'd probably initially start standing using one of the tilt tables, just because it gives us more stability. The problem with the tilt table, it actually it doesn't allow the vasomotor system to accommodate very well. Whereas when you actually stand someone through their feet, you actually get that dynamic plantar compression, which gives us a little bit more vasal return. So I think we try the tilt table, but sometimes people just can't cope with it and they just get very dizzy. We use supportive things such as compression stockings, abdominal binders, and monitor their blood pressure. But if they do start to dip, we may go for one of these standing frames. Would require probably 3 people to get them in initially, and then we'd get it back, we'd get them to 2 eventually. And these ones will put the feet on the floor, and then has a electric hoist system that brings them up into a very supported standing position. So it's always a tricky one for standing at this level.
So environment controls, again, now we've started to even experiment with the gadgets, as we say, Google, Alexa, those gadgets are being experimented to see if, because they are cheap, they're not too specialist, and they are quite intuitive. So I wouldn't say we are recommended, but we started to experiment whether they can be used at home. And one thing I would like to mention is even the specialist wheelchairs can stand people up. So sometimes they are the best one because people won't have 3 carers to put them on a standing frame. So some of our patients go with very specialist wheelchairs that can actually stand the person up, which is used for the therapeutic standing. But there is a cost. They are expensive.
C5. So C5 is a much more practical level to have. And as we know, manage incredibly well at C5. We started to get a lot more shoulder stability. We're starting to get posterior shoulder control, anterior shoulder control, all shoulder girdle activity, biceps, and supination, brachioradialis. So you've really got a lot of upper control in your arms. So we still haven't got the activity to give you trunk support, but you've certainly got head and shoulder girdle. At this point, what you haven't got yet is your hands and the wrist extension. So, you still can't straighten your elbows. The problem is, if you're always then bending your arms, you're at risk of then becoming tight in your biceps because they're always very active and you can't enable yourself to straighten your arms. So our concern immediately is to be careful about watching out for elbow contractures. Ooh, there it is. Okay, so this young man came to us from a hospital. He didn't get to us immediately after his injury, and so he was transferred into us like that. And actually, this is just using really basic. This is not high tech. As you can see, we took him down to class theatre and we made some back slabs. That's all we did. And we monitored his skin, bandaged them on, and used them with an ordinary Futura wrestling sprint and a thermoplastic paddle, and we put them together. So really low-tech management, and you can see it's really successful just by splinting. And an adjunct to that would have been that we would have added in FES as well, but just that on its own was successful for this young man, and so we were very pleased with that.
What's FES?
Oh, we'll get onto that. Functional electrical stimulation, there'll be a lot of that. You'll see a lot of that shortly.
So this was an example of the contractures that I mentioned. So all the patients of high level of injury are very, very prone to contractures, which means that if they can't move their arms or they can't move their limbs, the limb would take the shape of the surface they are on, and mostly, we've seen in one of the community visits that people have taken the shape of the bed. So that is what happens, that's what is contracture. We will address these contractures in afternoon sessions. So prevention is one big educational tool that you give to the patients. So, expected functional level. So we've got lots to work on as a therapist. So biceps, we've got elbows, we've got shoulders, we've got wrists. So we keep experimenting and exploring what function we can get from them. These patients can breathe independently. They would still need 24-hour care. So they would need people to help them transfer, to move them, but they have movement in the arms that we will use. So they are hoist transfers. They can push.
Especially with wheel assist systems like the wheelchair. It's a brilliant example of how that's so practical.
So it is the wrist. We've got the wrist, so we're going to be, I'll tell you what we do to get the wrist. We will teach them compensations, we'll teach them tricks to use the muscles that they have. So they can use touch screens very easily using just the positioning through their elbows. They can use their wrist and biomechanically use their wrist. They would have a standing program, so the frames, they would not need maybe such sophisticated frames needed in the earlier levels, but they would have a standing program. And all patients, when they leave the unit, they have a standing program because that's very, very essential. They can have wheelchairs, they can push wheelchairs, as Sue said, but the wheelchairs need to be quite light because they do not still have the full strength. So they need their lightweight chairs, power add-on system, which means they could have the wheels which are motorized. All the wheels need is a slight touch and the wheel will come into action. Equipments, patients of individuals of this level can feed themselves. So they would have, as I said, they can move the elbow, but they won't have the hands. So we give them straps, we give them splints so that they can hold the cutlery and feed themselves. We have a session in the afternoon on independence, engaging in functional class, and then we will just go through how we use straps and splints to enable them to have this function. drinking system we've already talked about. Environment control still is a good adjunct to the whole technology that they have access to. And electric bed, by this level they would be able to operate the controls of the electric bed. Not all, they have to be big controls, so they can slap with their wrist and use those controls. Can you talk about that?
Yeah. So then we get to C6. So at C6 we're coming to this important business of the wrist extension. So you can see we're looking at latissimus dorsi. Now latissimus dorsi actually takes some of its innovation right up from cranial 11 actually, so really high up in the spinal cord. So latissimus dorsi is sort of slightly out there anyway, but we start to get a full innovation. So latissimus dorsi, what does that provide us? What's it quite good about that muscle for those medical folk here? Where does it go from to? Where is it? Is it in my head? Okay, it's the torso muscle. It's the one that all the guys do the weight training and get that lovely V shape, yeah? Okay, so it's your torso muscle, but it's attached around the scapula and up around the vertebrae, the cervical spine, and then through a big fascial covering, which comes right the way down, sweeps all the way through at the whole of the spinal column, and then attaches and takes its attachment over the pelvic rim at the back. So because of that large expanse, it offers you stability. So though you haven't got innovation throughout the whole of it, you haven't got innovation of all the muscles around it. Because you have innovation in that dorsi, it can provide you with some trunk control if you can use your arms to prop with. So if you can put your hands by your side and use them to stabilise, you have the ability to rest and stabilise your trunk using your muscle. So that's an important functional gain for somebody at such a high level of injury. And then the other important functional gain, which I'm going to talk to you about in a moment, is wrist extension, which you can see is coming in here. So we've got quite a nice stable shoulder, however, still haven't got full stability. We do have a nice trunk control, so hands sit reasonably well with hands, and we have got wrist extension. Takes us to the exciting bit of team wrists.
So we've got two key functions here. Person can move the wrist up, and we will teach them tenodesis, which is a biomechanical trick that we teach the individuals. What the trick does is, it is completely biomechanical, and you all may want to try it. As you lift the wrist up, what happens to the fingers? Just try it. They bend, yes? You may not be doing it voluntarily yourself, but they would curl up. As you drop the wrist, what happens to the fingers? They straighten up. This is the tenodesis action. We will because we have wrist extensor, means the muscle that can move the wrist up. We will train this muscle. We will make this muscle strong so that people with this level of injury can actually lift an object purely through the movement of the wrist. Okay. And the other one, which we said brachioradialis, is another great muscle, which is a muscle that comes from just the forearm, but it is quite important in moving the thumb close to the fist so that they can grasp an object. So this is what is called tenodesis grasp training that we do for patients at this level, which would be where we use different modalities. We would use electric stimulation, exercises, they have hand therapy sessions just to practice different grasp. And then the other important function that Sue said, key function, they can prop an arms, they can lock their arms in a position so that they can sit and support themselves. They won't need specialist support all the time, they can support themselves, which gives us a huge opportunity of function transfers. So they can use the tenodesis grasp to do things for themselves. They can brush, they can comb, they can hold objects, they can participate in dressing. Just by this movement, they can put the clothes on themselves. And as you said, they have lats. What does it mean? Is they have some control in the trunk, so they are able to hold themselves and put the shirt on.
Just talking about the transfers, the only thing about the transfers, and it's absolutely key, is that guys can tend to do this. C5 men can do a transfer with assistance and a transfer board. Us ladies can't. And that's not all of us, but a large majority is generally because our arm to body length ratio is different, and we have a larger padding at the bottom that makes it harder to clear. So it's really quite tricky for us ladies to manage it, and I certainly, the small size of the body can't. And so, you know, if you've got somebody that luckily has lovely long arms and is very slim, they will manage it, and certainly most of the men can. But it's an expectation. You can always try it with the ladies, but they may struggle. It's just really hard to get any lift for them. And also, don't forget, us ladies actually just don't have the same upper body strength as a man would have anyway. So if you're looking at a child, it's not a problem. Up to the age of 11, there's no difference between the upper body strength of a boy or a girl.
So they can turn in the bed. If they have the rails, they would use their arms to put hook on the rails, and they can turn themselves. Transfers, we would again try different methods of transfers. We would use slide boards, sometimes slide sheets and slide boards, to see if they can prop themselves and get themselves across the board. Has anybody come across slide boards? Have you used it? You have. There are lots of heads nodding.
We're going to do some.
So we will do some of the practice in tomorrow's session. Yeah. So have you? So if you've used slide board, have you come across people of this level of injury where you've used propping?
Not in religious.
No. Okay.
We haven't seen anyone in the UK.
Okay.
Usually the equipment came from the UK,
Right.
yeah, or Asia. Malaysia or Mauritius, it's very difficult to get hold of these things.
And the gentleman at the back, you said you have experience with slide boards, and is it with this spinal or it's just?
No, it's with spinal.
Right. Or somewhere this level of injury where you talk. So.
It shows more about C6 than C5, but in the diagnosis it was like C5, and we know everyone that it's always subjective to the patients.
Exactly.
No patient, no two patients are similar with the same diagnosis.
Yes. Some very good C5s would be able to do it. It's just how they have been exactly. It depends.
So it means that you have got the sliding boards in the hospitals then?
And clinics.
Not exactly, but we have got like at university. I was teaching at University of Mauritius, so we have got sliding board that was used in the occupational.
No, but at the university, they're not treating patients regularly. I'm speaking of what happens in.
What normally I did when I had the patient, it was like someone I really knew well. So we had one fabricated by a carpenter. Yeah, mainly.
Yes, you want to say something?
In the hospital, in the public hospitals, it's bedridden if you have a spinal cord injury, regardless of the level. If you go to the private hospitals, they have a hoist only in ICU, but in the ward, there's no hoist. They basically use like sheet transfers to get you maybe into an ambulance, but the idea of getting into a car. Well,
That's certainly been what we saw when we came 2 years ago, when we went to Olympia. That's exactly what we saw.
Yeah.
So we would be addressing slide board transfers tomorrow in hands-on workshop. So it would be kind of problem solving. It will be interactive as it is here, because we know there are lots of issues of equipment. The beds are not always the height adjustable, but we'll address that. Okay. Yeah. So the equipment with lightweight wheelchairs, as we said, even the C5 will participate in wheelchair sports. There are specialists. Basketball sports, rugby. So they would be able to. They are specialist chairs. They look different, and they would be able to participate. They are able to drive. You can C5 will drive with specialist controls. This is C6. They can drive automatic car with hand controls.
Now C7, we get the magic muscle of triceps. So now you can straighten your arm and you can push yourself up. So it makes a big difference. So even if you haven't got full hand function, you've got your tenodesis and you've got your triceps to give you a push to hold and lift. So all of a sudden it starts to get a lot easier. And as you can see, you've got your innervation now around the wrist, starting to get your long flexors and extensors into your fingers. And obviously we get abductor pollicis at this level as well. So we're really starting to find we're getting an awful lot more that you can use. So this patient is really going to be very independent in the sense that they can actually move themselves around, and they are able to wheel themselves in a wheelchair, and they are breathing. And I'm not going to go on too much about the breathing because we're going to talk about that in respiratory after lunch.
Okay.
Mm-hmm.
So we have fingers in this level, which makes life very much better than the levels above. So and we've got triceps, which is the magic muscle, as you said. That means individuals of this level can transfer independently because they can lift, they can push themselves up. But they really, in terms of function, they're largely independent, but they would take longer time. Fatigue is one of the problems that they would face. Bowel and bladder management, they would be independent at this level because they have fingers. They can do the catheterization, they can manage their bowels, they can transfer. Bed mobility, yes, that is moving about in the bed. Even with their normal bed, they should be able to turn around, sit up, get themselves at the edge of the bed and transfer. But largely independent, they can drive with hand control. They can even get the wheelchair and load it in the car, and we'll teach them how to do that. Again, there is always special equipment for special things they want to do, so that is a whole area of how they choose a wheelchair that suits their lifestyle. Obviously, standing program, they would have standing program. Wheelchair skills, we would be teaching them. It's no good just giving them the wheelchair. We have to start from the beginning, how the wheels are propelled, where are the brakes. We start from there, and then we go to advanced wheelchair skills, which means we teach them how to manage curb or small step obstacles on the street. We will teach them how to do wheelie, that is balancing on the backward wheels, to get onto uneven surfaces, which is called advanced wheelchair skill training. And many times we have a specialist coming to our unit who is a wheelchair user himself. So then patients can associate it. He can do it, I can do it too. But sometimes they cannot associate with the therapist because what do you know about my disability? So this is a very, very important skill to give when they leave our unit.
So now we're right down into the hand, and we're going for the small intrinsic muscles. So really at this stage, it's the rest of pronation, the rest of flexion, and then really small muscles in hand and thumb. So this really is not very much different to your C7 level, except just full hand dexterity, really, full stability around the wrist. And so these patients are going to be pretty much the same in their ability to manage.
In terms of transfers, wheelchair skills, they would be as good as the level above. They live independent life. We have independent living unit where patients, just before their discharge, they would stay for a day, whether it's with their care or they live independently, so that they get this taste of being on their own, because in the unit they always have a team to address their issues. There's a call bell always to ask for assistance. It's quite intimidating going back to their home without having a trial. So we get them to stay in one of the independent living units, which is adapted to their needs, to just put them to test before they go home. The skills are the same as they would drive independently.
So now we're looking at thoracic spine, and as you know, as you come down the thoracic spine, you're innervating your back extensors at segmental level as you come down. So the lower you are, the more active control you've got of your trunk. It gets better and better. Where are the abdominal muscles innervated from? Medics, therapists, nurses? Somewhere thoracic. It's the low thoracic. So it's T6 and down. So just interestingly, we're thinking of a thoracic spine as somebody being a really good paraplegic, which they are, but actually they still don't have their abdominals until they get past T6. So they still can't cough. So we're going to talk about that with respiratory. Just bear that in mind. However, these patients do have upper trunk stability. That's going to make life a bit easier when they're sitting in a wheelchair. It's going to help us get them positioned and their posture supported better. they're able to move themselves around very successfully, they can transfer into more complicated transfers, and these patients can manage just about anything they need to live completely independently at this stage.
So, only thing I would like to add is that they have good breathing, but breathing is still compromised because of the level, so you would still see a bit of fatigue in this level. So, the transfers will get even more complicated. These individuals can do split level transfers, as we say. That means they can transfer from a low surface to a high surface, or vice versa. They can even lift themselves and get onto the floor, and then back from the wheelchair. This is we say that's the last bit in rehab is the floor to chair transfer. So they really have to be so fit to do that, and not all of this level would be able to do it. You still need some factors to go, individual factors. They are very independent in wheelchair skills, advanced wheelchair skills. They can backward balance on their wheel. They can manage steps. They can get in and out of the car quite easily. They can get on and off the toilet seat directly. So that they would have complex transfer skills and advanced wheelchair skills. They can drive, and again said standing. Everybody goes with a standing frame.
With a fairly basic standing frame as well, not a high tech.
Like in oswestry, I'm sure you
have
seen the wooden frames. We've seen them here. So
I think we saw some metal ones that are very similar. So they're just metal with a wooden base. That's sort of, I've seen some of them in the hospital. So then we go to the lower thoracic spine, and we've got the abdominals now, and you've actually got your full trunk control. So now really you're starting to get to the lower part of the spinal cord, and we're actually getting into the area of the conus and the cauda equina. So patients above that area, that level, will present with high tone of spasticity because they have an upper motor neuron injury. Patients at the lower level, where the spinal cord becomes the conus and then into the cauda equina, they're starting to develop symptoms of a lower motor neuron injury, which means they don't get spasms and spasticity, they have flaccid paralysis. So there's a different set of challenges in that, because you're actually then looking at the risk of developing pressure ulcers far more easily, actually because the muscle bulk changes around their legs and hips, they sit differently, so it's looking at their posture and getting them to sit well so they don't develop further complications. So these patients are obviously very able. They can take themselves upstairs, as you can see on that picture of our wheelchair practice, with someone with them, and they can do really complicated escalators and complicated activities. And we are also then looking at possibly starting to look at calipers, if that's something they wanted to do, walk with calipers, because at this level of injury you could go for a basic knee ankle foot orthosis and allow somebody to walk with that. There are more sophisticated caliper systems that are available that come up higher. That's not the exoskeletons, that's a completely different thing, but there are other reciprocal gait orthoses that come up higher around the pelvis for people at higher levels of injury. What we find with using these really basic orthoses is that they're heavy, they're very energy hungry, the patients get very tired using them, and so they can be very useful as a means to an end for some patients, but a lot of the complete injuries tend to give up on using them. They like the idea of having that ability to stand. It enables them to get up and down stairs at friends' houses, which is useful to use the toilet and things like that, and they can get into places they can't do in their wheelchair, but using calipers or these orthotics as a long-term strategy for a complete injury is very, very exhausting. And when we follow up our patients, the research shows that they like it, psychologically it's good. We never deny anyone a chance to do it, even though socioeconomically it's expensive. They're thousands of pounds to make, because we make the custom moulded orthoplastic AFO components and then the metal sides. There are very expensive lightweight ones available, titanium and all the rest of it. But again, patients do still tend to give up on them because it's too hard. If you have an incomplete injury with lots of activity below that level, then it's very useful because they've got more to work with. So it's just a tricky one from a walking perspective.
So I totally agree with Sue. A lot of people go with the AFOs, but they always have a wheelchair. And then after the follow-up, they would rather use a wheelchair because it's too taxing, it's too demanding, it's difficult.
You can't use your hands.
You
You've got your
can't
hands on
use-
crutches
exactly.
or a frame, so it's
And it's
frustrating.
exhausting, and in life one has to get things done when they're out and about in their homes. They have to get ABC done, go to work. This is not practical. They're completely independent in their own care, and they're very independent in domestic tasks as well. So in terms of domestic, we teach patients how to use a Hoover if they're in a wheelchair. So because they would be living on their own, people of this level may not necessarily have a carer. They would be independent. So that means home tasks, shopping, going out, everything is done by themselves independently. And they would be driving a hand-controlled car, and they would get the chair in, out, so much more they can do.
I suppose it's fair enough to say that that's in the world where there's a lot more accessibility and it's not so challenging to get around, so they can manage without a carer because they have good pavements with drop curbs, access to shops and things like that. We know that's not the case here. We've been and looked and we've talked to your government about the fact that's not the case here, or actually the fact you even have pavements in places really. So that's, I think it's really reasonable that somebody at that level in certain parts of Europe and certain areas you can possibly manage, but I think realistically we would say that might not be the case for somebody here because you just don't have that ability to access things independently, and it's a really challenging environment. So bear that in mind.
It is a teamwork, as we said. The hospital team works on its own to get the person to the maximum level of function. Then you have the community team, which will work towards environment, maximizing the interaction with the environment. So, and hence we get the function out of the person, the independence out of the person. So it doesn't work on its own. It has to be two together.
I'll whiz through these last
Yes.
ones. These are, we're at time. I've just realised. Well, I'll just whiz through these last couple of slides. So these is your lumbar levels and down. So as you come down, as you can see, you've got your hip flexors in the upper lumbar, L1, L2. So you've got somebody who could walk using CAFAs or any sort of other supportive orthoses to give you hip flexion. And so again, it could be something that would be an option. They do still use a standing frame because they've got hip flexion but not extension, so they get hip flexion contractures. So they need to stand in a standing frame to stretch, otherwise they will become contracted because they're using their hip flexors all the time. And then unfortunately, with the hip flexion contractures, then they won't be able to do anything. So you've got to keep that in mind, and they need to stretch. And we can explore options for them. Hand control still for driving, obviously, because they aren't able to. L3, you're coming down further, you've got your quadriceps, so now you've got knee control, and you've got your hips, but you still haven't got your glutes, and you haven't got your hamstrings, so you still can't extend, so you're still falling forward. So these people are always walking with a walking aid here, in flexion, so this whole risk of hip flexion contractures is a problem. However, obviously much more able to manage. They can ambulate with orthoses, and we can fiddle around with how much orthotic support they need, but they will still have to use walking aids, which is still exhausting, puts a lot of pressure on their shoulders. So they'll probably be a part-time walking aid, part-time wheelchair user if they're a complete injury. Very unlikely to be a complete injury, very rare. These are incomplete usually, with some activity below that level and some in one leg. So it's very rare to see it. I don't think I've ever seen a complete L3 ever, and that's a long time of working in spinal injuries. I've never seen one. So it's unlikely. Then you're looking at your caudal equine patients. You're looking at patients with flaccid paralysis, legs that are then obviously at risk of losing bulk. Looking at all sorts of different walking aids. These patients still haven't got their glutes, so they're walking with a Trendelenburg gait because they've got no hip control. So you're obviously being very mindful of protecting their joints and looking at things you can do to support them in their walking pattern. And they probably will still use a wheelchair for long distances. And then right down now to ankle eversion, dorsiflexion, and you're starting to get some glutes now. and you're starting to get a bit of hamstrings. So things get a lot easier. These patients do very well. Quite often don't actually end up using much at all, and some of them just use the small elasticated foot supports, the foot-ups or boxier splints, and actually come away from their AFOs. Unless they're getting a lot of hyperextension problems, we take them out of the AFOs, or they use very dynamic AFOs, ankle foot orthoses, ones that are very springy, that allow a good rock over and gives them far more dynamic activity, so it's not so difficult to walk. And then we finally get gastrocnemius, we finally get propulsion. So it's really down the bottom when we get the rest of the glutes and your push off, your foot off. And that's the problem, you're not getting the propulsion off to step. So again, it's very exhausting because you're always walking on a flat foot and there's no propulsion to take you stepping over. So just bear in mind, but these patients will ambulate, obviously, very well, the community ambulation. And right at the very bottom, we talked about it earlier, with these sacral segments, the bladder, bowels and sexual function, and the implications of that for the patients. And really, that so much is the team support, really, because these patients are walking around and they look fine, but they've got massive, massive issues that really impact on huge parts of their life. And they some of these patients don't go out because they're frightened they're going to have an accident, and they're walking. So they've got sort of abdominal activity, so they're going to press on their blood and bowels, and then they have an accident. So it's really devastating. So these patients need very careful support. And there's all the links, all the different sites that we're talking about there. Sorry.
Well, I think you will deserve a coffee break. But what I would say is that I'm aware that it's a lot of information to take in. And if you are in a rush when you're examining patients, when you're seeing patients, you will not have the time to go into all these details, but it is important to go into these details, because what the lady was saying earlier, people are just bedridden, and that's totally unacceptable, because we can do much better than this. But hopefully, let's work together so that in 1 year's time, we can change the face of rehabilitation in this country. So any country started somewhere. So let's not be critical. We're aware of what's happening. Let's just move forward and try to see how each one of us can help to change the face, especially the quality of life of people who have been affected by this problem. This can be any member of my family, friends, etc. And I'm sure that each one of you must have known somebody who has either had a stroke, brain injury, or spinal cord injury. The last point I would say, that we speak a lot these days on television about the number of deaths from traffic accidents, but do we ever speak about the number of people, 500 each year, who are injured, have severe injuries, and who live a life of misery? It seems that we forget about them. Do you agree with me or not?
Have a coffee break, and please have only 5 minutes of coffee break.
You can get your coffee.
Yeah,
Coffee and cake outside.
Stretch your legs.
Stretch your legs and come ASAP back, please.
Okay.